Excellent presentation, and clearly she's thrown down the gauntlet for you. So next up is Dr. Wald, a professor of clinical medicine and the medical director of the shock team and mechanical circulatory support at University of Pennsylvania.
Okay, Phyllis, challenge accepted. And Marwan, thanks for the toughest topic to speak on. Delayed MCS support, temporary MCS support is better. I changed the topic. I said late MCS support is better than no temporary MCS support and better than everyone getting temporary MCS support. Phyllis went through the definitions of mild, moderate, and severe right heart failure. And as Phyllis alluded to, that you can see in terms of survival probability, if you have more severe right heart failure, especially right heart requiring inotropes for more than 14 days or temporary MCS support, your outcomes were much worse. I don't really like using risk scores, so when I think of can we predict right heart failure in a patient that's undergoing durable, LVAD, we look at various parameters, right? So it's summarized here on this slide. The echo, what's the TAPSE, what's the RV look like, what's the RV to LV ratio? Jerry Estep, I think's group published that if you have a really large RV compared to the LV, you might get into trouble. RV stroke work index that came out of the Joe Wu paper, CVP to wedge ratios, and the PAPI scores. And with that, along with the clinical factors, you can hopefully try and predict whether somebody needs a temporary RVAD. Interestingly, when you look at the ECHO guidelines, ECHO alone is not felt to be a good predictor of the need for temporary right-sided support. And so Phyllis, putting a temporary RVAD in everybody might not be good, because we know the more we poke and prod patients, you might get surgical infections. And if you have a surgical site infection, you delay discharge, you have comorbidities. This was a patient who had a temporary RVAD. Granted, he needed it, but when they removed the device, you can see the atrial pacer lead is now pacing his liver. Then there's also the risk of hemolysis. And Phyllis, so you can see here that if you have somebody who has a drastic change in their renal function post-LVAD support, regardless of what it's from, then their outcomes are worse. So what strategies also, as Phyllis alluded to support the RV if you need it? And this was the study that Phyllis also showed that if you require supplemental RV assistance, is it ECMO or is it RVAD? And by this paper, RVAD is superior to VA ECMO. However, okay, Phyllis, you win this one. Any support intraoperatively is still better than delayed support with leaving. However, can you find data to the contrary? Of course you can. You can Google and find anything. So this is Koji from Columbia, same institution that said delayed RVADs was worse. Look at that. Delayed RVAD versus concomitant RVAD, the outcomes were the same, with the conclusion that although the outcomes in patients requiring temporary RVAD were worse than those who never required it, using the timing of decision in this case did not matter. Just use it when it's clinically necessary. I knew you were going to show this data, Phyllis, out of Penn, that in the white box, LVAD alone, outcomes are the best. Planned RVAD, not as good, but way better than those who left the OR and had to go back for RVAD. But Phyllis, I don't know our age difference, but this is a really old study. And so this is a really old study, and you pulled it out, but I think if we were to be more contemporary, and our younger colleagues might teach us that there are better devices out there now for RVAD support, and you can do it so that it's less invasive, it can be removed without going back to the operating room, and they can ambulate. This is my partner, Asad Uzman, waving in that little picture there, and he puts in our temporary RVAD devices for us. And usually if we know that it's going to happen, he's putting in an IJ and a fem line, and then in tandem to the patient, the surgeon doing the surgery, he's lining them up for the temporary RVAD. Another thing he does is to put in placeholders. So if the patient's leaving the OR and looks pretty good, that maybe they might not need an RVAD then, but then they go into AFib with RVR or something unexpected, then he can put it in at the bedside in 15 minutes without going back to the OR. This is also a contemporary review of all the different right-sided devices that we have out there, and you can see that there are some disadvantages and limitations to all of these devices. And so we do need more data. We do need to look more studies, especially with the contemporary devices that we have, that they can ambulate, it can be removed at the bedside and not going back to the OR. This is for the fellows and the APPs in the room. Something that I really want you to take home is to really be able to recognize right heart failure. Because if you miss it, it's really bad for the patient. So if the patient leaves the operating room without a temporary RVAD, they come out and you can see on the top, stable hemodynamics, early right heart failure, moderate right heart failure versus severe right heart failure. And what we're looking at are the CVP, the PA pressure, the variability, the cardiac output, and then the treatment for each phase. So you're stable, you're starting to wean, try not to wean too fast, but with right heart failure, you might start seeing the CVP go up, and maybe the PA pressure start to go up. Back up on what you were doing, go back up on the inotropes, restart the Flowland. But if it was missed and you keep going, now you start seeing the CVP going up even higher, and now you might not be filling your VAD. And you see the variability or the PI start to drop. Now you've got to make a decision. If you don't reverse course right away and salvage that patient, they're going to slip into the final column, which is severe right heart failure, when your PA pressures drop, you're not filling your VAD, and now you're not perfusing your end organs. So in conclusion, Phyllis, early recognition and rapid deployment of temporary MCS is essential, but not everybody needs one. So you can put in placeholders and use contemporary devices that can be removed very easily. Because if everyone gets extra lines, you risk other complications. So try the placeholder technique. You also have to differentiate right heart failure from tamponade. So if some hints might be that your mediastinal tubes stop draining, and that your mediastinum is widening. So just make sure you keep an eye on that. So with that, it was super fun to debate you, Phyllis, and thank you so much.
So very exciting, and I will say, I think she's learned the first rule of debate, and that is, if you can't attack the argument, attack the person. Wonderful job. So before you leave, before you step down, we are trying to save time, but I still have a little bit of trouble with the semantics, though, right? Okay. So wonderful that they can put a line in, they're back in the ICU, and you can put it in 15 minutes. Yeah. The fact of the matter is, it's 3 hours later. Yep. Right? Because it took a while to get out of the operating, to stop the bleeding, to get out of the operating, to get to the ICU.
So here's my argument.
So wait a minute. So the issue is, that's not delayed implantation?
Definitely
that's
delayed
3 hours.
implantation.
So,
however, but they left the operating room stable, right? So in this instance, something went awry in the ICU. So we're very conservative. Yeah, exactly.
Well,
they went into AFib, or they bled, they gave a unit of blood.
For everyone else, though, because it's the idea that they're stable, though. Because for many people, right, they're on epinephrine, Primacor, inhaled nitric oxide, vasopressin, and their MAD index is 2-ish. And the idea is, they were stable. The answer is, no, they weren't, right? They're barely getting by.
Stable-ish.
So I want to be careful as what we decide as to what is delayed versus an immediate sort of resuscitation. I'll get you 1 second, Annie. So Dr. Fiedler, real quickly though too, is I have a real problem with this idea of unplanned, right? Because everyone says it was unplanned. Because what it tells me then is when it was discussed with the surgeon and you have a patient in the ICU pre-op on 2 inotropes, a low index and a CVP of 15, as a surgeon, you went to the OR with no plan for what to do if their now VAD flow is low. So do you ever do unplanned RVADs in the OR?
Do I personally?
Yep.
That's a loaded question. Failure to prepare is preparing to fail.
Yeah.
So, no, I don't think so. I think the clinical situation that you present, I would be very well prepared to do an RVAD in the operating room. And to the debate, for me, and I would argue for the rest of the panel and most folks in the room, if you're on rocket fuel and you're even thinking about coming out of the operating room following a durable LVAD without an RVAD, that's a failure. You need to put something in, and you can put in whatever you want, and we can debate until we're blue in the face if a surgical approach or a percutaneous approach is the best option, but that RV needs to be addressed before you leave the operating room.
Correct. Yes, I don't like, and I realize it's old terminology, but this idea that there's unplanned RVADs is it just tells me, though, it's the team didn't prepare well. So we're behind, and Ali tried to ask a question last time, so I'm sorry, Eddie. We're going to let Ali ask one quick question, then we got to move on.
I have to say one thing, Mark, on your comment, because I love Dr. Slaughter, just remember definitions and thresholds have to be defined by patient individual. Remember the Slaughter doctrine that we talked about 10 years ago that ultimately failed, but I still love you.
I think regarding the argument to say you want not send the patient in ICU with high pressures and they get the RVAD there. You can bring the C-arm to the operating room and protect you without any delay, and that's what we do. And I think that's the remark, and the important thing for us to say, there's no one solution fits all. Yes. There's some patient will do very well with the percutaneous, some patient, a big patient, you need more flow. I think the surgical solution might be the best solution. It's a decongestion. I think is the key issue, how we are going to achieve that. With percutaneous or surgical, I think the ECMO, we should use it less now because we have better devices, and the ECMO was more in a history, but I think we have better percutaneous devices which could be used.
Yes.
Thank you very much.
Thank you very much. That's great.
Thank you so much. Great debates, but I would end.